Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and Med Talks, I welcome you all to yet another episode of 52 Weeks of Diabetes Essentials with Dr. Sanjay Kalra. Now, today's topic is a very interesting topic, anginal equivalents. And today's session is brought to you by your zero calorie hydration drink in result zero. Now, before moving forward, I would like to announce the last week quiz winners. Dr. Sanjeev Puri from Hoshiarpur, Dr. Bharat Praveen Mittakota from Surat, Dr. Nayana Sheth from Mumbai, Dr. Gangadhar Rath from Bhubaneswar, Dr. Madhusudan Aril from Bangalore, Dr. Pratap Parkar from Navi Mumbai, Dr. Pradeep Padathe from Vashi, Dr. Satish Kumar Jain from Bangalore, Dr. Surjit Kalsi from Noida, Dr. Pradeep Patro from Chhatrapur, Dr. Shantanu Kumar Bhattacharya from Kolkata, Dr. Shashi Khare Bhopal, Dr. Sumita Sharma from New Delhi. Now, I would like to welcome our host, Dr. Sanjay Kalra, President, South Asian Federation of Endocrine Society. Over to you, sir.
Thank you, Ankur, and warm greetings, everybody. Today, we'll be talking about something that is very important. We'll be talking about the sounds of silence. Now, the question you'll raise is, how can sound be silent? Or how can silence be a sound? This actually happens in medical care. It happens very frequently. And one of the issues that we'll discuss is anginal equivalents. Now, many times the absence of a symptom, the absence of a complaint is cause for complaint. It is cause for concern. Let's take the example of diabetic neuropathy. Some patients come in with painful neuropathy. Others come in with painless neuropathy. So when the patient comes and says, my legs feel numb, my feet don't hurt at all. You can pinch them, you can poke them, nothing happens to me. I walked on hot water, I walked on glass, nothing happened. That is a sign of concern. Similarly, in heart disease and in diabetes, silence can also be a sound. It can be a sound of heart disease. And this very poetic phrase, the sounds of silence, was coined by Stern et al. And they mentioned a few aspects of cardiovascular disease, atherosclerotic cardiovascular disease, which uh, suggest that the patient is sick, that the patient has got heart disease. Now, in general, we equate heart disease with angina, with pain, with chest pain. But all patients don't present with pain, especially those with diabetes, because their pain receptors, their pain pathways are affected. So they might present with dyspnea, breathlessness, palpitations, easy fatigability. All these can be symptoms of atherosclerotic cardiovascular disease. They can also be symptoms of heart failure. Heart failure itself can be because of atherosclerotic cardiovascular disease. It can be non-atherosclerotic as well. So dyspnea, palpitations, fatigue, they can be a symptom of, they can be a marker of heart failure plus minus ASCVD. Some patients will present only with erectile dysfunction. So that is also a vascular dysfunction. It is an endothelial dysfunction. It's just that because of instead of the coronary arteries complaining, the pudendal artery is complaining. But if there is a dysfunction in one vascular bed, whether pudendal or femoral or cerebrovascular, carotid, there can be a dysfunction. There are increased chances of dysfunction in the other vascular bed. And this can be the coronary one. So don't forget to listen to these sounds. Also take a family history. If there is a family history of premature ASCVD, premature atherosclerotic cardiovascular disease, occurring below the age of 40, then that means you have to take action. So we have to be more aggressive in our preventive therapy. Let's simplify this subject for ourselves and let us make it as simple as A, B, C, D, E. So this is our topic for today. How do we assess persons with potential CVD in the clinic? Now, when you look at patients with hypothyroidism, it's quite easy. You segregate them into overtly hypothyroid, euthyroid, and those with subclinical hypothyroidism, subclinical. But in ASCVD, in heart disease, you have four aspects. One is patients who have absolutely no CVD, no cardiovascular disease. But there will be very few such patients in your clinic because we don't do the test for all. There will be others with established ASCVD, whether coronary or cerebrovascular or peripheral arterial disease. If we are in a primary setup like me, we will not have so many patients. If we are in a tertiary setup, we will have lots of patients with ASCVD. So this is relatively easy to handle. Those with established ASCVD, those with no ASCVD. But there are two more classes. One is the class of patients with subclinical ASCVD. Subclinical means they will not have any clinical symptoms. They will have no clinical signs, but they will have laboratory or imaging abnormalities. So if maybe you do a microalbuminuria, you do a lipid profile, you do an NT-proBNP, you find that these are high. Maybe if you do imaging, it can be, of course, TMT is outdated now. If you do an echo or if you do a calcium score, a coronary calcium score, you find that that is abnormal. So this is patients with subclinical ASCVD. The fourth and the last group, which is most difficult, is those with atypical CVD, those presenting with atypical symptoms. And in the acute setting, ABCDE means patients presenting with atypical site pain, anywhere from the angle of the jaw, that is the mandible, up till the umbilicus. It can be ASCVD. Patients presenting with breathlessness or dyspnea, clamminess of the skin or diaphoresis, wet hands, moist hands, dry mouth, all occurring at exertion or upon exercise. So atypical side pain, breathlessness, clamminess of skin and dry mouth occurring upon exercise or exertion. All these are symptomatic. They are states and they are suggestive of anginal equivalents. So deal with them that way. Do not forget to investigate. And if at all you are worried or you are confused, err on the side of caution. Extra investigation does no harm. In the chronic setting and also sometimes in the acute setting, you might have patients with A for arrhythmias. So you might be able to palpate the pulse and see that something is wrong. The ECG tells you that something is wrong. Now, some arrhythmias are benign, others are not. So check with the cardiologist. The prevalence or the incidence of atrial fibrillation is supposed to be 1 in 100. That means that if we see 100 patients in the OPD, we should be picking up atrial fibrillation in at least one out of them. Now, all atrial fibrillation is not always continuous. It can come in bouts, it can be paroxysmal, it can be intermittent. But still, we should be aware. A for arrhythmia, B for biochemical abnormalities. Biochemical, for example, microalbuminuria, dyslipidemia, high NT-proBNP. C for claudication, that is suggestive of peripheral arterial disease. So claudication pain means when the patient is at rest, there is no issue, but the moment the patient begins to walk, there is pain in the legs. Claudication time means how much time the patient can walk without pain. Claudication distance means at what distance the patient develops pain. D is for dizziness, which can be a sign of postural hypotension, cardiac autonomic neuropathy. And E is for erectile dysfunction. And all these suggest either myocardial or polyvascular bed involvement, whether it is claudication, that is femoral artery bed, dizziness, that is cardiac autonomic neuropathy, or erectile dysfunction, which is pudendal arterial bed dysfunction. So this is ABCDE. Let's remind ourselves. Atypical site pain, breathlessness, clamminess, dry mouth upon exertion. Arrhythmia, biochemical abnormality, claudication, dizziness, erectile dysfunction. All these are important because when we manage diabetes, we have to take this into account. We have to take the entire glucophenotype into account. And we have used the word glycemic personality earlier in Diabetes Essentials. We have spoken of sure, secured. Let's assure ourselves that we are on the right track. And when you look at assure, you have to be aware of the associated complications and comorbid conditions before you begin treating. That is why anginal equivalents are important. You have to be sensitive to social realities, the patient sensitivity, the severity and style of hyperglycemia, the utility and urgency of glucose lowering, and also the relative risk of hypoglycemia. If you have a patient with cardiac autonomic neuropathy, there are chances that the patient will have other forms of neuropathy as well, and that may include hypoglycemia unawareness. So go a bit slow. If the patient has postural dizziness, postural hypotension, avoid drugs which are very potent blood pressure lowering molecules. And in assure, E is for expected efficacy. So make sure that you use the right combination of drugs so that you are able to achieve target. But here in assure, we focus once again on A, associated complications and comorbid conditions, which include subclinical or atypical cardiovascular disease, atherosclerotic cardiovascular disease, and anginal equivalents are a form of understanding these. So now let's ask ourselves our quiz questions. The first question is, in the acute setting, anginal equivalents include all except atypical side pain, breathlessness, clamminess of skin, and maintaining a healthy lifestyle. Which of these is not an anginal equivalent? Question 2. How do we treat anginal equivalents? Do we treat with nitrates in pills and sprays? Do we treat with long-acting nitrates and skin patches? Do we treat with antacids or with both A and B? Of course, this would be emergency treatment. So how do you treat an anginal equivalent? With nitrates, nitrate pills and skin patches, antacids, or both A and B? With this, we come to the end of today's talk, but we have many questions lined up today. I'd like to thank everybody for having logged in. Question from Dr. R.K. Dutt from Kolkata. Can person with diabetes eat mango and banana? The answer is yes, sir, in moderation. So how do you explain to your patient? If, of course, glucose is 400, 500, we tell them to hang on for a week or two, don't eat. Otherwise, how do you cut the mango? You can slice it very thinly, or you can dice, D-I-C-E, dice it into squares. You can make mango raita. So you make raita, that is hung curd, and you also put small pieces of mango in it. No sugar. Same for banana, small pieces of banana. We can also make mango ice cream at home. Just milk and small pieces of mango or banana in it, and you put it in the freezer. So mango or banana raita, mango or banana ice cream, no sugar added. And these are ways in which the patient can take mango. Mango shake, banana shake would be a very bad idea because it increases the glycemic index. Thank you, Dr. Ravi Shankar sir from Chennai, for your kind words. Dr. Kadri from Nanded in Maharashtra asks, which is the best sulfonylurea in CKD? The best one, sir, would be a very humble molecule, that is glipizide, 5 milligram tablet, 5 OD or 5 BD, the most economical also. Otherwise, second best or equally best would be glyclazide MR. So choose between glyclazide MR 30 and 60 once a day, or glipizide 5 milligram or 10 milligram once or twice a day. Dr. Pranshu Verma from Gorakhpur, thank you, sir, so much for your kind words. And as long as you are with us, the program will continue. Dr. Saurabh Singh from Vikram Jyot in Ayodhya, that is the center of India these days. And thank you, sir. And if there is any shortcoming from our side, please let us know, Dr. Saurabh. We will try to improve. Okay. Linagliptin and metformin is available in the market now. This question is from Dr. Shanti Ranjan Biswas in Kolkata. I think for some time it was short in the market. The FDC is not irrational. Maybe there was a supply chain issue. It is available now, 500 and 1000 both, 850 milligram also. 850 metformin plus linagliptin. Dr. Shanti Ranjan asks about imeglimin. So imeglimin is a drug that I use frequently. IME, imeglimin, GLIMIN. This is a molecule developed in Japan, which is a dual action glucose lowering drug. It increases insulin sensitivity at the level of the skeletal muscle and the liver, two organs, skeletal muscle and liver. It also increases insulin secretion, especially first phase insulin secretion, also second phase. So first phase insulin secretion is increased. So if you have a patient with high postprandial hyperglycemia, 1 hour PP hyperglycemia, this is a good drug to use. Because it acts upon the liver and upon the skeletal muscle, it helps in reducing fasting glucose. Fasting glucose comes from the liver from hepatic gluconeogenesis. It can also work as an exercise mimetic. So people who don't want to exercise, their skeletal muscles are not insulin sensitive, they become insulin resistant. Imeglimin can help improve that. You can use 500 BD and then go up to 1000 BD. The 500 tablet is much smaller than the metformin 500 tablet, so patients don't find an issue in taking it. And you can also use it in chronic kidney disease, 500 OD or 500 BD. Dr. Arshad Beg from Sitapur shares that many patients have got normal glucose but high HbA1c. In India, sir, that is right. The HbA1c is usually reported slightly higher in everyone in India. And another diagnosis is that when patients come to you, then they behave nicely. So they behave properly because they are afraid of Dr. Beg Sahab, so they will take care of their diet and exercise 3-4 days before coming to the hospital. That is another diagnosis. One other diagnosis is that we are checking glucose usually fasting and PP after breakfast, but we are not checking after lunch or before dinner. So we can tell them to check glucose at that time. Maybe the after lunch, before dinner, or after dinner, glucose levels are high. So we might have to add a small tablet in the evening or at dinner time. Dr. Shekhar Bhave asks a difficult question from Jalgaon, which is the most preferred gliptin in my practice. So I can answer that honestly, it is linagliptin. There is no substitution. It is slightly expensive, but there is no substitution, and you can use it irrespective of renal or hepatic status, renal or hepatic health. Apart from that, I use all the other drugs as well. I use vildagliptin and sitagliptin both, but linagliptin is what I prefer the most. The most economical is vildagliptin. That is why I use that. Vildagliptin we should avoid in patients with moderate or severe hepatic insufficiency. In patients with renal calculi, Enerzal Zero can be used safely. This query is from Dr. Ashwin from Chennai, Tamil Nadu. And the advantage is that it increases hydration and prevents deposition of crystals. Dr. Dharmaraj Chauhan from Parbhani in Maharashtra asks us to speak about HIV and tuberculosis and diabetes. So, sir, please allow us to do this in separate program. Tuberculosis national program mandates that glucose should be checked at regular intervals in anyone on ATT. In general, if your patient on ATT is very catabolic, then it is a good idea to start insulin. In general, if your HIV patient is very catabolic, it is a good idea to start insulin. However, if patient is doing well and has normal body weight, normal body habitus, then the same standard of care will continue. First metformin and then you add whatever you want. In catabolic patients, it is good idea to avoid SGLT2 inhibitors or GLP-1RA because they will worsen the catabolism. So drugs of choice will be metformin, sulfonylurea, and gliptins. If patient is on ATT, then there are chances of hepatotoxicity. Same with HIV therapy. So then maybe we would want to avoid vildagliptin and we would prefer linagliptin. To Dr. Suresh Patil from Dhule in Maharashtra, thank you, sir, for being with us. And to Dr. Vijay Ahirao from Sakri in Maharashtra, workout for diabetic patients. So suppose your patient has never exercised before. 3 steps. First of all, balance and flexibility. Let us try balance ourselves. Stand on one foot. I'm doing that now. 10 seconds. Keep your hands in the air also. Then the other foot, 10 seconds. So you've done balance. Then flexibility. Move all your arm, your limbs, upper limbs, lower limbs, cervical area, trunk in every possible uh, direction. Try to use the complete range of motion. That is flexibility. Once you've got the hang of that in 1, 2, 3 days, yoga is very good for that. Even after doing yoga, you will have muscle pains for 1 or 2 days. Then we move on to aerobics. Aerobics is of 2 types. One is low impact aerobics. Low impact aerobics means at any point of time, at least 1 foot will be on the ground. So now if I am walking or sort of marching on the spot, which I am doing, this is low impact aerobics. If you've succeeded in doing that, then you move to high impact aerobics. High impact aerobics will be contraindicated if somebody has osteoarthritis or osteoporosis. In high impact aerobics, like in doing bhangra, at any point of time, both feet may be off the ground. So if I jump up, now that was high impact aerobics. This should be around 70% of the exercise, but not 100. The other 30% should be resistance exercise, which means upper limb and lower limb muscle building. So this is something that I myself don't like, but you can always use your books as a resistance exercise. Now, what I see most right next to me is Charak Samhita. This is my copy of Ayurvedic medicine. But if I do this, see, so now this is resistance exercise, which I'm doing at home. So this is the way to work. In general, 5 by 7 aerobics 2/7 resistance exercise. This is general for everyone. For specific people, supposing somebody has sarcopenia, somebody lost all his muscles after COVID, then you need more of resistance exercise. Someone with someone who needs weight gain, then resistance exercise will be better. So, Dr. Vijay, I hope I've been able to answer the question. And let's begin practicing today at home. Dr. Ramesh Gaikwad from Valgaon, Amravati, Maharashtra asks why there is a variation in blood glucose levels in various laboratories. Sir, it depends upon the time taken, the time between collecting the value, the test, and actually checking the value. So, the longer you keep the sample in the lab, there will be glycolysis, irrespective of how the sample has been collected, even if fluoride has been put in it. So the longer you keep the sample, the more glycolysis and glucose levels will come down. If you check glucose immediately, then glucose levels will be normal. You will get the accurate value. If you check after 6 or 7 hours, there will be a 30% reduction. And from Gujarat also, Dr. Vora Saeed from Veraval. Thank you, sir. And same thank you to Dr. R.B. Singh from Behraich in Uttar Pradesh. Behraich is on the Nepal border. Thank you, sir. If HbA1c is high in dehydration or if hematocrit is high, the chances of vascular complications go up. So Dr. Subrata Bhattacharya actually is trying to point out that first you manage the dehydration. If patient comes to you with hyperglycemia, the first thing you do is put an IV line and you push IV fluid if patient is sick. The second thing is you give potassium and insulin. So the first is IV fluids. And hats off to Dr. Ashok Kumar Agarwal from Gorakhpur. Hats off to everyone actually, because it is together that we are able to work towards a diabetes-free or diabetes complication-free country for ourselves. With this, I'd like to thank everyone for having been with us today. We'll continue to meet each other every Sunday, and there are many pending questions that we have from our 20th real-time date when we ask questions. We look forward to being with you and to keeping this conversation going forward. Thank you once again, and I'll hand over to Ankur from Team FDC.
Thank you so much, sir, for enlightening us regarding and taking your time and questioning each and every question. Uh, Thank you so much, sir.
Thank you and Jai Hind.